Please welcome Dr. Lynn Goldman, the Michael and Lori Milken Dean of the Milken Institute School of Public Health at George Washington University.
Thank you so much, and good morning, good afternoon, or good evening to you all, depending on where you are at this very moment. From wherever across the United States or around the world you may be joining us today, I am delighted to welcome you to our 30th annual Gibbs Oration, 14th annual COIL Lecture, and our 18th annual Young Alumni Presentation. While I know I'm not alone in saying I look forward to a return to in-person gatherings, I'm so grateful to our MHA Alumni Association leadership, the faculty of our Health Policy and Management Department, and our partners at the National Capital Healthcare Executives for putting together today's fully virtual experience. I'm very excited to let you know that for the very first time ever, our school has 2 alumni recognized by Forbes in their top 30 under 30 list. One of them, Kang Vuong, is a graduate of our MHA program. He founded a company called Mira, which is providing affordable healthcare to people who are or underinsured. He went through the GW Office of Innovation and Entrepreneurship's I-Core Site program a couple of years ago. It is certainly testament to the great success we have had with not only recruiting great healthcare management students, but also teaching and mentoring them, as well as providing outstanding encouragement through our entrepreneurship program. I think all of us are in for a real treat today. Our health management program has been educating and training healthcare administrators and providers for nearly 6 decades, starting with the vision of Frederick Gibbs. From his early nurturing of a unique idea, actually training students in hospitals, to our programs now, both residential and online, I could not be prouder as Dean of how this trailblazing program has evolved over the years. Faculty leaders like Professor Emeritus Dr. Kurt Darr and Dean Emeritus Dr. Richard Southby, both I believe are online with us today, and current leaders like Dr. Bob Bonar and Dr. Lynn Friedman have built upon Professor Gibbs' legacy to develop our MHA program into one of the best in the nation. Our faculty leaders over the years have been supported by a tremendous alumni body, easily one of the most engaged groups across the university. MHA alumni are generous and committed in many ways, including as guest lecturers, adjunct faculty, mentors, preceptors, employers, volunteer interviewers, and very importantly, as donors. MHA alumni philanthropy established endowments for both the Gibbs Oration and COIL Lecture, and annual giving from alumni, faculty, and friends provide scholarships and professional development funds for our students year after year. Thank you to all of our donors who are joining us today. Many thanks as well to all of today's remarkable speakers. I am looking forward to hearing from each of them, and I'm sure their remarks will give us a great deal to think about and to discuss. Thank you, Wayne Brackin, for moderating our Gibbs Oration. It seems appropriate that we mark the Oration's 30th anniversary with an impressive C-suite panel of MHA program alumni. Thank you, Chris, Bonnie, Deneen, Jason, and Jennifer for being here today. And I am delighted that Dr. Lauren Powell will deliver this year's COIL Lecture. I am confident Dr. Powell's courage and passion for public health and health equity will inspire us all. And I should say, I think that my dog agrees. Mally Hunt, congratulations on being our young alumni speaker today. I'm looking forward to your remarks as a rising star in long-term care. I also want to recognize and thank Howard Gershon for rounding out the day's alumni speakers with a special session on transforming behavioral health care. Lastly, throughout the day, I encourage you to use the chat function in Zoom to connect with new friends and catch up with familiar faces. It is now my pleasure to turn things over to our MHA Alumni Association President, Kelly Laura, an exceptional alumni volunteer and someone whose leadership I truly value.
Thank you, Dean Goldman. Welcome, everyone, again to the 30th Annual Frederick H. Gibbs Oration, hosted by the Alumni Association of the Masters in Health Administration program at the George Washington University Milken School of Public Health, in partnership with the National Capital Healthcare Executives chapter of the American College of Healthcare Executives. My name is Kelly Laura, the MHA Alumni Association president and double alumna of GW with both a bachelor's and master's degree in health administration. We thank you all who are attending, as well as our speakers, for the tireless work you've been doing to support our communities and the healthcare industry through the COVID-19 pandemic. We appreciate you joining us today during these times to hear from all of our GW Alumni C-Suite panel, discussing our future of healthcare and where do we go from here. Your participation today is eligible for 1.5 qualified education credits, which you can enter yourself into your My ACHE account. This panel includes a discussion among panelists, as well as a question and answer period at the end of our session. At any time during this session, please feel free to enter in your questions for the panelists into the chat box within Zoom, which may be selected by our moderator to pose to the panelists. At this time, I would like to introduce you to our moderator, Wayne Brackin, a 1986 graduate of our program and former president of the MHA Alumni Association. Wayne is currently serving as the CEO of Kidz Medical in Coral Gables, Florida. Thank you, Wayne.
Thank you so much, Kelly, and thank you for your tireless efforts in making this day a great success. Also, thank you, Patrick Sanders, for your tremendous support with the program today, your ongoing philanthropic efforts, and with keeping our alumni strong and connected. Thank you also to Lauren Allen for your behind-the-scenes efforts over the last few months. I'd like to thank Dean Goldman for her national leadership, as this pandemic has shown a bright light on the critical role public health and healthcare leadership plays in our nation. The Milken Institute and the George Washington University have shined even brighter during this critical time. By the way, Dean Goldman, I'm your loyal Twitter follower, and your content is always important and enlightening. And you'll see a number of retweets from me. So I encourage everybody on here to follow Dean Goldman. We have a fantastic turnout with attendees from at least 26 states and the district, as well as internationally from Toronto and Amsterdam. We have quite a number of distinguished alumni in attendance as well. Elliot Cohen, Jack Buckley, Fred Brown, Stan Grube, Fred Messing, David Gitch, and Howard Gershon, who we will have the pleasure of hearing later on in the day. On behalf of multiple generations of alumni, I would like to salute Kurt Darr, who had a profound impact on the trajectory of our careers, and therefore on healthcare in the United States. I'd like to also acknowledge that one of our outstanding alumni was just presented with the 950 Award by Dean Goldman. That's Peter Fine from the class of 77, who's the president and CEO of Banner Health. I'd like to welcome all the students attending today, and for you, the sky's the limit. I'm most gratified that 4 of my past administrative residents are in attendance today. Tashina Williams, Raman Singh, Rabi Javid, Tom Gardner, all survived a year with me and were outstanding, and I'm happy to see them continuing to do such good work in our country. I'd also like to, I'm welcoming 2 students doing internships with us in Miami, Alexa Rubin and Sarah Abbasi. Finally, I ask you to consider making the Milken School's Health Services Management and Policy Program one of your philanthropic priorities, so it may continue to generate the knowledge needed to protect the health of the American people and to turn out the next generation of healthcare leadership. We have a very distinguished panel of healthcare leaders, innovators, and role models today. I'd like to take a moment for us to get to know each one of them. First, if I could ask Bonnie Panlasigui.
Sure, I'd be happy to speak, and thank you for the honor and privilege to join this panel today. I am here at St. Mary Medical Center in Long Beach, part of Dignity Health with Common Spirit Health. I've been in the industry for about 14 years, served in an associate administrator role for about 5 years and 6 years in a COO role. I am very grateful to have a very supportive husband who is a stay-at-home father. I have a little 4-year-old daughter. And so for all the working parents out there, I give you kudos. And over the years, I've had the privilege of being involved with different types of associations. One of them was the Asian Healthcare Leaders Forum, now part of ACHE. I was one of the founding members and was honored to be a recipient of the Modern Healthcare Up-and-Comer Award back in 2016. I want to give credit to our alumni today. There is no way that any of us would be here where we are if it weren't for our alumni serving as mentors to give back to us. And so I want to give recognition to Arthur Shore. I'm sure many of us would not have chosen GW if it weren't for somebody who told us or recommended us to choose GW. And Arthur has been so great to so many students. And Stan Grube, who I know is in the audience today, he propelled my career in a way that I would have never been able to do on my own. And so I just want to give him honor and recognition as well. But just want to share, I've been here at St. Mary Medical Center for about 2.5 years in the COO role. We are a 389-bed facility, level 2 trauma center, level 3 NICU. We are a recipient of many awards. Long Beach is located in South LA County on the border of Orange County. And we have quite a bit of competition around us, pretty robust healthcare system here in the Southern California area. And I'm looking forward to being able to speak further with you all about our experiences.
Thank you so much, Bonnie. Dr. Chris Dixon, please.
Thank you, Wayne. And thank you, Dean Goldman and Kelly and Troy for the invitation and opportunity to speak here today. I am a practicing anesthesiologist for 23 years. Kind of pains me to say that now. But, I went to GW through the executive MHA program as a means to learn how to bridge the conversations between providers and administrators. And I have to say that since going through that program, I've received that and so much more. It is kind of it has really opened my eyes to just kind of how wide and deep healthcare and its administration, its application touches our lives in so many ways. And I continue to use those lessons daily in my roles. I have been a full-time practitioner. I have been CEO of a small surgical hospital, and my current role is chairman of the Department of Anesthesia at Coliseum Medical Center here in Macon, Georgia. So thanks again. I am grateful for my experience that I received from GW, and I am grateful to be able to share those experiences with the panel and the guests today.
Thank you, Dr. Dixon. Jennifer Wilkerson, please.
Hi, everybody. It's a pleasure to be here with this group. And I think back to many, many years ago when I chose GW, frankly, because it was local and I wasn't planning to move. But I will say one of the things that I had heard about the school when I was applying was that the alumni network was strong and had served people well. And I can't say enough about how well it has served me and how well I hope I have served past or future generations after me. And so it's really a pleasure to connect with this group as always. I am currently the Vice President and Chief Strategy Officer at Sheppard Pratt, which is the largest private nonprofit behavioral health care system in the country. They've been there coming up on 2 years. And prior to that, I spent a little over 17 years at MedStar Health in the strategy and business development world for hospitals and service lines.
And Jennifer, you also are past president of the Alumni Association as well, correct?
I am, yes.
All right, thank you. Deneen Richmond.
Hello, good afternoon, everybody. It's nice to be here. I'm Deneen Richmond, and I and have a recent title change. So I, about at the end of September, was asked to serve as the acting president at Luminis Health Doctors Community Medical Center. Right before Thanksgiving, our board passed a resolution and asked me to assume that role on a permanent basis. So it's great to have that opportunity. I've had the wonderful experience of spending my entire career in the greater Washington, D.C. area, which has been wonderful in a variety of roles at hospitals, health systems, the National Committee for Quality Assurance, federally qualified health centers, quality improvement organizations, you name it. I feel like I've spanned the healthcare industry. Just a little bit about Luminis Health. We are a relatively brand new system. We became a system last July of 2019. And we are here in Maryland, right outside of Washington, D.C. Doctors Community Medical Center is in Llano, Maryland. We also have facilities in Anne Arundel County and Annapolis, Maryland. We consider ourselves to be a very, very much community-oriented health system. In fact, you see community in the name of my organization. So I have some opportunities to really share with you some of the important work that we're doing in the communities that we are privileged to serve. So thank you. I guess the last thing I should quickly add, I would be remiss if I didn't add that one of the other hats that I wear is serving as an adjunct faculty member in the MHA at GW program since 2015. So shout out to all of the current and former students in that program who are joining us today as well.
Well, congratulations on your permanent appointment. We could probably do a whole panel on the difference between being acting and permanent CEO. But it's really, it's a great, they made a great decision. Jason Rose, please.
Hi, good afternoon, everyone. I'm Jason Rose, and I'm the CEO of AdhereHealth. I've been in the healthcare and healthcare technology field for about 30 years now. And going way back to the early 90s, I started in the technology area of the Medical Faculty Practices Association, the group within GW, and decided to go into school in the Health Services Administration program. So was a full-time student, full-time working in IT. That actually led me to an opportunity to discuss what I wanted to do with my career back in the early 90s. And I saw a great opportunity for technology to provide an incredible influence into outcomes for healthcare, reducing costs to improve quality of care. And I pitched my idea of creating a program to the faculty at this business school where the program was at the time I was a student, and asked them to allow me to create my own program that was focusing on technology. And through the entrepreneurship and innovation of the group, they accepted it. They allowed me to create this program for myself. And I ended up, instead of doing a residency, ended up doing an internship, a graduate internship at Cerner Corporation, which I'm sure you all know. And I'm actually the first graduate intern of Cerner, maybe the only one, I'm not sure. But I do credit GW for allowing me to step outside the box and do something different that I felt very important. And that starts back from the medical center when I worked there and into the program. Over the last 30 years, what I've done is built a career in, first half of the career was really in the provider side, working for hospital systems, working for electronic health record companies and things of that nature. And the back half of the career focused more on the healthcare payer the managed care organization side. Still on the technology side of the front, I eventually got into the business side of leadership and focused on how do we enable technology to improve value-based care outcomes. And so I'm happy to say I feel like we're making a great impact. We're going to talk about that more here today in this next hour or so. And I currently working for a company. I moved from the DC area to Nashville, Tennessee, and I'm the CEO of a company called AdhereHealth. And AdhereHealth is a company that's really focused on leveraging medication adherence gaps and identifying where there are problems in what's called social determinants of health to overcome those gaps and improve upon the outcomes. And I've really enjoyed the opportunity to meet with everyone on this panel today. I look forward to discussion.
Thank you so much, Jason. Just a few years ago, we had the late CEO and founder of Cerner come and speak to the MHA students at the Milken Institute, and I have to say it was one of the most moving and emotional talks I'd ever heard. And the way he connected compassionate care to technology was remarkable. So I'm sure
Neil Patterson.
I'm sure you remember him well. Yes,
absolutely.
Yes,
wonderful human being.
So thank you all panelists for your introductions. It's obviously an impressive group, and you have brought great honor to the Milken Institute. So let's go to our first question. Our first question will go to Bonnie. Bonnie, we have been through an enormous societal upheaval over 9 months. While many of us have been through a crisis in our professional careers, earthquakes, fires, hurricanes, bombings, they usually affect a specific part of the country for a short time. We've not in our lifetime ever witnessed and survived a nationwide health crisis as we have faced with this pandemic. I'd like to ask you to tell us about your experience at Dignity Health managing through this crisis and how it compares to past responses to more easier to anticipate disasters. Bonnie?
Thank you, Wayne, for the thoughtful question. And I'd like to start first by sharing a very brief reflection. In politics, business, sports, and family, the words cooperation, collaboration, and teamwork, they're not just great words, but they're really, truly great strategies. And I just want to quote a few very famous people that I think will resonate a lot with us as we have this discussion. Helen Keller said, "Alone we can do so little, together we can do so much." Henry Ford said, "Coming together is a beginning, keeping together is progress, and working together is success." And lastly, and most importantly, Harry Truman said, "It's amazing what you can accomplish if you don't care who gets the credit." I think that is the number one out of all of the quotes there, the one that means the most to all of us as healthcare leaders in this industry, because now more than ever, we are learning from each other and we're sharing ideas from each other. And at the end of the day, it's not who gets the credit. It's what's being delivered to our patients in our communities. It's really honestly a very humbling opportunity to speak on this topic today, because I know I'm only one leader of only one hospital, and I'm only going to be speaking for what we experienced. And the stories that I'm going to share are not unique. I know in the audience, there are so many leaders that have gone through the same exact thing, because this is a nationwide and a worldwide pandemic. And so we all share the same burdens, the suffering, the same joys, the same heartaches. But regardless if you had one COVID patient or if you had 100 COVID patients in your facility, whether it's long-term care, acute care, even surgery centers or clinics, we were all equally impacted in different ways. And so I'll share my stories and experiences from being a member of one of the largest health systems in our country, part of Common Spirit Health. I do want to share a personal story. There's a patient that we had the honor of discharging who had been one of our first COVID patients. He was in our hospital for over 4 months. couldn't see his family for over 4 months, 87 years old, was on a ventilator in our ICU for over 3 months. And he was successfully discharged. And I want to give credit to our CNO because she came up with the idea to do something called a code happy. And what that is basically we announce overhead code happy, and all of our employees that have the ability to come down to the main lobby, we line the halls and we cheer for our patients that have COVID that have been successfully discharged and able to go home. And I just remember that one celebration just being so emotional. And it was so nice to be able to see him reunite with his family outside the front doors of our hospital. And I know that a lot of you all have experienced similar reunions. And so just wanted to share that one story. But what Wayne was asking about, emergency preparedness, unlike any other disaster, this one is very similar and very different in many ways. I'll talk about what's similar, whether it's a hurricane or a tornado or an earthquake. It really takes down everything in its path. Multiple businesses and lives are taken down at the same time. It's chaotic, and we have to make very timely decisions. And you have a sense of helplessness. And we did feel that. That was what we felt in the very beginning when all of this started. A lot of businesses impacted, a lot of lives impacted, people losing their insurance, not able to come to the hospital, feeling scared that they may either contract COVID or either not be able to afford the care. But there's also some things that that really were really evident, was that there was a lot of staff burnout. And that's something that I'll speak very briefly to in a little bit in this response. But I want to share with you what our surge plan looked like. And I'm sure a lot of this will be similar to what you all may have experienced at your hospitals. But the question is, if you build it, will they come? What we did in the beginning is we created makeshift ICU units. We converted our PACU and our GI lab into ICU level beds. We converted an entire med-surg unit to be able to handle tele patients that we needed to monitor. We partnered with the Los Angeles Surge Hospital, and we were able to send our COVID patients there as overflow if needed. As you all know, we received the naval ship right by our hospital in Long Beach to be able to offload non-COVID patients if we were to reach that capacity. And we held daily incident command meetings following the HICS guidelines. And so all of that emergency preparedness we did ahead of time with all the other types of disasters came in very handy. We were struggling in the beginning. We were trying to get ventilators, and, you can imagine all the hospitals at the same time trying to get ventilators from the same companies. So it was nice to be able to see companies step up here in the United States to be able to manufacture some of those quickly. And we quickly purchased as much PPE as we could get our hands on. And I want to speak to something that's very interesting, is normally we have a supply chain method that's just in time. That's very different now. Now it's how much can you build in your stockpile to have ready and on hand for future types of emergencies that are similar to this, if this were to happen again. With much help from our corporate office, which we're very grateful for, and I feel for the hospitals that may be standalone that had to come up with some of these ideas on their own, we were given visitation policies, the screening process was outlined for us, and processes on the infection control for testing our patients in the tents outside of the hospital, and much assistance when it came to communication with our employees and talking points. And so just want to give kudos to our corporate office for being able to supply all of those tools for us. But how did we communicate with our employees in a time where things were different? Yes, we continue to do face-to-face daily rounding, but we also did virtual town halls. We made sure that we told the unions in particular how much PPE was on hand every single day, because we didn't want to be one of those hospitals that had negative media about not having enough PPE available. So we had to make sure that we were over communicating on every single aspect that we could possibly think of. And what did we do for our employees? Because, being on the front line, it's a very scary time. They were scared to go home to their families. We created sleep rooms. We converted one of our lower utilized units and made that entire unit to be sleep rooms with showers, so they didn't have to necessarily bring that virus home to their family, that they could shower before going home. The foundation provided free hotel rooms for up to 2 weeks for our employees. And the state of California also partnered with hotels to give discounted rooms for employees. As many of you all saw at your facilities as well, such an outpouring of very much generosity from restaurants offering free food for our employees. We created a grocery store in the cafeteria when all the hoarding was happening and when there were long lines to get into the grocery stores. We wanted to make sure that we provided necessities for our employees to be able to quickly purchase before going home to give to their families. We created a relaxation room specifically to decompress and a special area just for the employees that we didn't have before. And we created a COVID bonus. We gave it to our employees who interacted with the COVID patients. This was a little bit of a lessons learned here. We had some pushback afterwards because the departments that did not get that bonus felt as if they should have received it. And then I spoke with one of my colleagues at Cedars-Sinai, and they actually did the opposite. They gave a COVID bonus to all employees, regardless if they were staying at home remotely or working with COVID patients. And the response there was interesting as well. They said, we don't feel like we should get that bonus, the ones that stayed at home, and they actually kind of felt bad. So it's interesting the response that you get from two different types of actions. But as far as Wayne's question on what's different in the second wave, a lot of the things are created now. We have those processes in place that we were scrambling to get in place before. We have that reserve of PPE available. We know what we're doing to screen the patients. We're not jumping quickly to stop our elective cases. And so those are things that we know that we have better medication available for our patients and not have to jump to ventilators. As far as lessons learned, we had some civil unrest. That was something that we never experienced before. The rioting and looting right here in our backyard on top of a pandemic. We had graffiti, fences knocked down, a pharmacy broken into. We had to board up areas that had our PPE stored. And it was an interesting situation where, we never realized that we were having to deal with two different types of disasters at the same time. And the other thing that I know a lot of organizations are struggling with right now is the staff leaving, whether it be to exposure or to getting the virus itself, but also employees who are leaving to join agencies that are paying up to $250 an hour for crisis rates that we can't possibly compete with. And so even though we may have ICU beds available, we may not have the staff to provide the care. So we're looking into changing the ratio requirements for the state of California to see if we can get a waiver to have a higher level of patients per ICU nurse. And one of the silver linings of COVID that Wayne had asked me to speak on very briefly is the telehealth. And we have taken full advantage of that. In fact, we offered a free service. If you put in the code COVID, you don't get charged for your first few visits for family medicine, diabetes centers, OB clinics. And we've even instituted it starting now for ED, non-urgent type of visits. We're thinking that since we did the drive-by testing at our hospital, we may do drive-by vaccinations. We're actually in the midst of preparing. How do we administer the vaccine? How do we anticipate side effects? Where are we going to do the administration of the vaccine? How many will we get at the same time? We just received our large negative 100 Fahrenheit sub-zero refrigerator for the vaccine, and so we're in the midst of deciding who will be first, and a lot of ethical decisions have to be made. But lastly, I just want to close that we're always going to have pneumonia patients, flu patients, COPD, sepsis. In fact, our ICU that's maxed out right now, 90% of the cases are non-COVID. We have a lot of very sick patients who have postponed their care for 9 months because they were either afraid to come in or they just thought maybe I can just hold off a little longer. And so I just want to reiterate that it's important that we realize COVID is going to be around for quite some time, and we're going to have to learn how to work with COVID as any other diagnosis in our hospital. And so just want to thank you for allowing me to share just very briefly our experiences. Again, this is only one hospital, but hopefully this was helpful.
Very, very, very helpful, and I think that those of us who have gone through these different types of crisis find that your reaction and the kind of things that you've done, Bonnie, for the people that work there and are caring for the patients, they never forget it, and I can tell you that it goes on for a lifetime of gratitude, and there's really just there's no substitute for that kind of loyalty that comes out of going through such a tough period of time. But by showing them that you care, and by really taking care of them, they will always be there. And even some of the ones who leave, they come back because of the way that you treated them. So congratulations to you and St. Mary's and Dignity Health. Deneen, could you follow up with some comments on the same question?
Sure. So, I think all of us are having to, as Bonnie was sharing, deal with, what is still very much so a novel virus, a novel disease. And so that comes with a number of challenges. But what I want to briefly focus on is what we have advanced, what we've learned, and things that I would say in my own organization and probably in healthcare as a whole, we would not be doing today had it not been for COVID. So our focus has been we center our focus around how are we going to keep people in the community healthy? How are we going to care for people who are infected with the virus? How are we going to prevent worsening disparities? Because you can't, every headline is showing us the disparities that were already there that are really just being accentuated by COVID. And then along with that, how are we addressing social determinants of health and moving our population health agenda forward? So when we looked at how we're caring for our patients, I think like what Bonnie was saying, our acceleration in the adoption of virtual health options, a variety of different virtual health options, has skyrocketed just since March. And I don't think that would have otherwise happened as quickly as it has. We have telehealth I call it telehealth on steroids now. So as people were becoming concerned about coming into our facilities, we wanted to make sure that we could keep our virtual doors open and still provide them with excellent health care. We have accelerated our programs around remote patient monitoring, which is allowing us to discharge some patients who maybe otherwise would have been admitted, but to discharge them directly from the emergency room and send them home with remote patient monitoring devices, and using our care coordination teams, our primary care physicians and others to once again provide them with daily, multiple times a day, touch points in safe care. We have expanded the way that we are focusing on community health. So as everything was shutting down earlier this spring in the state of Maryland, schools closed, businesses closed, the state was shutting down. We like to say that we ran out into the community. So we are one of the few health systems that actually have had boots on the ground, community teams of care managers, community health workers, and others literally going into our most vulnerable communities and populations. They aren't tuning into the news every day. They aren't checking the health department's website. So if we want to get information to them and reliable and accurate information, we need to go to them. And as we identified what some of their needs were, we've put together COVID care kits that have cloth masks, basic culturally appropriate educational materials. We've been going out to food distribution sites. We've gone to sites where day laborers were as we started seeing the Latino COVID positivity rates increasing in our communities. So those are things that really have allowed us to greatly just build on the population health and community health approaches that we had in place. And then we've had a lot of care innovation. And we all know that from a time a protocol comes out to when it's widely adopted is typically years. So when you look at the advances that we've made just since the first surge to where the second surge that we're in, I should share that, this morning, I woke up to a patient census of 62 COVID patients, with about a third of those in critical care. I have critical care boarders in my emergency room. So we are clearly right in the midst of our second surge in the DC area. But having these advanced protocols, having the remote patient monitoring options and the telehealth virtual healthcare options, having our community team that can go to people and meet them where they are and provide them with safe care. And the last thing that I would just add is just the increased need for testing. So back in the summer, we actually stood up a community-focused testing site. We're testing about 1,000 community members a week. We have partners with our local health department, with a local church and a local municipal government, but it's been wonderful. And we chose that site because it was in a community that had a lot of challenges and didn't have easy access to testing. So we were one of the first sites that was no doctor's order required, no appointment required, walk up and drive up, because not everybody even has a car. And so to be able to meet those needs and then not just provide them with COVID testing, but identifying other unmet health needs and being able to meet those needs. So I'm a glass half full person. So I like to focus on a lot of the positive things that have really advanced the way that we're delivering care. And then also, as Bonnie mentioned, just also really focusing on how we're supporting our team in dealing with this crisis as well. So thanks. It's been obviously an experience that we all would hope we didn't have, but it's definitely one that we've learned from and one where we've been able to advance healthcare and health outcomes.
Well, I would say based on what you said, your glass is 3/4 full. That was really a remarkable number of things that happened, and it makes it even more crystal clear why they selected you as their permanent leader. Let's stay on telehealth for our next question. And let's get a different perspective from Dr. Chris Dixon. From a technical standpoint, the ability to incorporate telehealth technology into the practice of medicine has long existed. If there's a silver lining in this crisis, it's been the transformative utilization of telemedicine as a major part of the response to the pandemic. The convergence of need, user friendliness at both ends, easing of regulation, and parity and reimbursement made this happen. Dr. Dixon, what's been your experience over the last 6 months, and do you believe that this telemedicine, virtual care change is a permanent one to our healthcare culture?
Thank you, Wayne. The short answer is yes, but my experience over the last 6 months has witnessed an embracing of telehealth. I think most people would automatically assume some of the younger providers, younger generation providers would more readily adopt the technological solutions. But even amongst those older generations and me, who's in the middle, I've also recognized that even where there may have initially been some reservations, it has served us well in terms of being able to treat patients who, as has been alluded to, had reservations about coming to the hospital or who may have been actually infected themselves. So the but part of that is that there's still some heavy lifting to do in terms of again, as been alluded to, the challenges that telehealth may or may not be a magic bullet for. Of course, it expands and makes more convenient access for patients to providers and for providers to patients. That swings both ways. But access requires there are disparities in healthcare that have been highlighted, and there are disparities in digital access too. There's a digital divide among certain communities, and putting a digital divide next to healthcare disparities can either bridge that gap or it can expand them. And so I think there's still focus that needs to be had, as Dr. Richmond alluded to, grassroots efforts to go out and help bridge those gaps in communities that may or may not have access to some of the means to take advantage of those conveniences. The other part is, it's in rural communities and not just urban communities. There's still, it can serve as an access point, but there's still a certain level of infrastructure that has to be installed and paid for in order for them to take advantage of those conveniences. So while telehealth, yes, I believe it is here to stay, and yes, I believe it's going to help well into the future with curing some of the ills that we all know exist. There's still some focus that needs to occur to make sure that we are able to, as a society, more totally and fully take advantage of all that it has to offer.
Great. Thank you, Dr. Dixon. Jason, could you follow up with your perspective on some aspects of that question?
Yeah, absolutely, Wayne. So Winston Churchill said several decades ago, never let a crisis go to waste. And what we've been talking about for the last few minutes has been an opportunity as much as a challenge, if anything. So if you think about from a avoidable medical cost perspective, widely publicized data for many years is over $500 million are avoidable medical costs due to medication adherence issues. That's staggering number. That's 16% of the entire U.S. healthcare spend can be avoided if patients actually follow clinical guidelines and take the drugs. There's a lot of reasons why they don't, but that is a really core issue that isn't discussed enough. And this is an opportunity to focus on that. If you look at the consumers and our citizens that are most at risk, it is in specific zip codes. It's not the genetic code, it's the zip code that is the real problem. This is before COVID was here. It's during the pandemic, and it's going to be after the pandemic, that there are those individuals who don't have the proper access or health literacy and other areas of social determinants of health, which I like to think of as Maslow hierarchy of needs for healthcare: food, water, shelter, access, and all those things that go into why they actually aren't getting their drugs. They don't understand why they should take them or why they're not getting the proper care. And so I do see a grand opportunity to take advantage of an awful situation and do things such as telehealth, which is a really important underutilized benefit that's been around for quite a long time. We finally have the government has approved that after several administrations not allowing the government to providers to bill for that. But we're only at the very beginning of telehealth, because what we're really talking about with telehealth are urgent and subacute issues that might get some attention. We're not doing anything, or very, very sporadically, telehealth with respect to chronic care management. And that is an opportunity to continue to focus on leveraging technology, continuing to use data to identify those who are most at risk, whether it be from social determinants of health issues or looking to see if they're taking their medications on a real-time basis. Those are the types of things that we should be using technology for and for telehealth. So a couple things about my organization, AdhereHealth. So we have about 1,000 clinicians, or employees of ours, across the United States. We are a technology company first and foremost. We typically work with healthcare managed care organizations and providers who take risk on their populations. And we also own a pharmacy that provides pharmacy private couriered directly to the consumer's home, hand delivered, not through mail order, but hand delivered. Because if you think about these individuals who are most at risk, again, mail order is not going to work. Often they can't even walk to their mailbox. They can't get to their pharmacy. They can't get to Walgreens because they no longer have the support that they had once before to get to a pharmacy. They really need more attention. And this is the top few percent of the populations that really are driving the highest level of cost, which again is the same population we're having issues with today. So one of the things that AdhereHealth did is that we took a look at all the data that we have, and we have about 30 million consumers in our data set nationwide. It's about 10% of the United States. And we looked at the data and we said, well, what is going to be a problem? We already know that these individuals are at high risk. What can we do about it? So started with, I wrote a blog, in the healthcare blog, if you're familiar with that, widely held online blog, and talked about these types of things. That if you think about Occam's razor, that is the most. If you look at all the issues and challenges that we have, focus on the most straightforward reason of what we can do to focus on overcoming those issues. And so if you think about the aspect of pharmacy and issues with access and health literacy, and ensuring that people understand the importance of that and getting the proper care and authorizations to get that pharmacy, that's a big part of the issue. So the CDC put out a data point of only a couple months ago that said 94% of the people who have passed away had 2 or more, I think it was actually 2.6 chronic conditions. And those are the people who've passed away, not from COVID. For all those people who passed away, it's actually from the chronic conditions themselves. And the COVID has exacerbated it. And so focusing on identifying those high-risk populations proactively using data, because those people were probably not taking their medications before, and identifying them through pharmacy claims data, using a clinical team that's behavioral health and behavioral motivational interview style skill set, and reaching out to these consumers and talking with them about what are their problems. Are they having issues? Are they having problems in accessing medications? Are they having problems accessing their doctor? Do they understand their telehealth benefit? Do they understand their health plan benefits? Do they need access to their doctor through different benefits that are available to them? There's community resources that are available to them as well that they are probably not aware of. And it's really important to identify those STOs issues one patient at a time using the data we have available. And then using that interaction, how do we then overcome that problem for that patient and follow through all the way and resolve the problem? So the solution that we ended up with, we called it the COVID-19 adherence solution. It actually ended up being Fierce Healthcare's top innovation awards and top 3 finalist award for top innovation of the year for healthcare. And so we're really proud of that. I do think that that will stick, and it's important to incrementally move the bar and not slide backwards. And I have high confidence that we will.
Well, thank you, Jason. Congratulations on the Fierce Award. That's a fantastic recognition for you and your company and your organization. Next question is going to Jennifer Wilkerson, and it's called, the topic is post-election prognostications. With the change in administration in January, we can expect significant attention and action regarding healthcare in the United States. The Affordable Care Act in particular will be revisited with regard to access, pre-existing conditions, cost of care, and Medicaid expansion. How fast and far can they go with these issues, including the consideration of a public health insurance option? Jennifer, please.
Sorry about that. I don't know how that happened. I was saying that I needed to get my crystal ball out. So there's still a lot of uncertainty. We really don't know, of course, exactly what's going to happen. I think some of what we do know is that Biden is surrounding himself with experienced Capitol Hill people. And he's doing that because he knows that's where the action is going to be. With all the uncertainty, with the Georgia election actually going to determine whether or not the Democrats control all three parts of the legislative process, even if they end up with that control across the three areas, there will still be such a slim margin that bipartisan compromise will have to occur. And so the answer to the question whether we will see fast or far on anything, I think, is probably no. It's conceivable that the House passes a public option, certainly. I don't think you'll see that in the Senate, regardless of what happens with the Georgia special election. You still have several seats that are held by Democrats in purple states, and they're not likely to go very far on any of these issues. We do think that there will be significant action by Biden's team on the regulatory process, essentially undoing some of what had been done by the Trump administration, certainly. Regarding the ACA, I think that we will see Biden seek to augment and reinvent some of it. Again, the real question will be what happens in the Supreme Court. So, for every sort of action, there's a reaction, I guess, is what we're seeing. There are several issues which we know have bipartisan support, and we can expect to see some progress in those, clearly on drug pricing, price transparency. We've talked about telehealth, certainly. There's support to continue in those areas, moving us further along. And then for behavioral health, which of course is the focus for my organization, we have seen historically Biden's strong support for parity laws and substance abuse disorder treatment, and so hope to continue to see those efforts in the next administration.
Always been a great strategic thinker, and it's very good to get your perspective. And I guess probably a reality check is a good way to think about what you have said. There are some other aspects I know that were of interest of the Affordable Care Act, interest to Jason. Jason, could you give us a few brief comments?
Yeah, absolutely. So again, I'm really coming at this from in a lot of ways a value-based care point of view. Spending my time mostly with ACOs and with health plan payers. So I strongly believe that value-based care has had great momentum over the last decade. I think the ACA was a huge part of that. Many don't understand, not people in this room, of course, but don't understand how sweeping that reform was, not just for exchange membership and adding about 15 or so million members that didn't have health insurance before, that were uninsured, but the tens of millions of Medicaid members that expanded upon in a managed care environment, getting more care coordination and more support and alignment in value-based care principles. And so as examples of that, the Medicare Advantage star ratings program, if you all are familiar with that, that's part of the Affordable Care Act. It's a $7 billion funding every year to provide an additional premium. It's about $500 per member per year for each member that the health plan has in a 4-star or higher plan out of 5 stars. And that has had widespread implications in terms of alignment between the providers and the plans. And I think it's worked quite well. 52% of the weighting on how CMS measures that is on medication-related issues. It's 52%. And we're seeing Medicaid states follow the same path that Medicare follows. I won't call it a prognostication. It is actually a fact, is that will continue to grow. We have 24 million of the 55 million Medicare beneficiaries are in a managed care plan for Medicare Advantage. By 2025, regardless of administration, it'll be 35 million. And then by 2030, it'll be 55 million. And that's per the Congressional Budget Office numbers. And that's been right on target in terms of that. So I do think that that's going to continue to help, and it's going to help contain costs, improve value. There's also continued focus in terms of other value-based care programs. There was an ACO announcement, big one, just yesterday. I'm not sure if everyone saw that, where they're doing the next version of the accountable care organizations. And so that is going to advance beyond a lot of the challenges were in the Medicare Shared Savings Program ACOs. There were a lot of problems in the foundations of how that program was orchestrated in benchmarking and risk score and quality, and actually incentivizing the beneficiaries or the participants, consumers themselves, as a part of their health, which is a major flaw I saw in the program. And that's been starting to get resolved in the new ACO announcement that occurred yesterday with CMS. So we see that consumer experience is going to be a major part of the regulatory reform in all these value-based care programs, not just in the ACOs I just described, which is a major part of that new regulation. It's also in the star ratings, and it's also in the Medicaid plans. Is how does the consumer get value out of their doctors, out of their pharmacies, and out of their health plans? How do they feel about it? It actually is a really great opportunity to focus again on social determinants of health. So if we overcome social determinants of health issues, that will equate to consumer experience improvement. And that equates to literally billions of dollars in reimbursement from the government, because that is part of the law. So I do see that will continue to grow, and I'm very enthusiastic about, regardless of a President Trump or a Biden, I don't see that changing.
Thank you, Jason. I really appreciate that you can shine a light on a part of the Affordable Care Act that most people don't know about and overlook, but it's clearly a powerful driver through that reimbursement that really changes practice. Our next question is going to Deneen. Every crisis exposes institutional and societal weaknesses, and that has clearly been the case with the disproportionate effects of COVID-19 on Black and Brown communities. One of the ways that these public health weaknesses can be highlighted, exposed, and addressed is by having a proportionate representation of those communities that are receiving the highest levels of impact, including senior leadership at healthcare institutions, board membership, and elected officials. How well has your organization dealt with these matters prior to the pandemic? Lessons were learned that we can address post-pandemic. Deneen, please.
Yes, thanks, Wayne. So this is a very important topic. And as you mentioned, I mean, we're all seeing the devastating, there's really no other word for it, impact that COVID is having on our Black and Brown communities. But one of the things that I'm very proud of is that, as you mentioned, what were we doing prior to the pandemic? Because these issues didn't just happen with the pandemic. So in my health system, we have been, I would say, a little bit ahead of the curve, but also recognizing that there's still so much to do, as we're seeing with what the data is showing us today. Back in 2009, we actually added diversity as one of our formal organizational values. And at that point in time, implemented a number of programming and initiatives around truly embracing the diversity. And several years after that, we actually, as we were continuing to do that work, formed a governance-led health equity task force. And that task force really helped us to focus around 2015, 2016 on a number of very key priorities, and I'll just briefly share those. So we recognized that we had a lot of work to do 5 or 6 years ago around ongoing data collection and analysis. Without data, you really don't know what's happening. So we've had a real focus, we have had a focus on real data, race, ethnicity, and language data, really looking at how we were collecting that data accurately, how we were measuring it. Most recently, the last several years, we've also have had focused efforts around our SOGI data collection. For those who aren't aware with that acronym, that's sexual orientation and gender identity, another very important area. And it's not about just having data, it's about analyzing that data, understanding where we have disparities, and then doing real work around those disparities. So one of those areas where we found a disparity in our data was around C-section rates between our African American and Caucasian populations. So that's just one of a clinical area where we've been focusing on that disparity. We realized that, there's a lot of blind spots. So we've had a lot of focus around communication and awareness and education and training as well. One of those areas where we focus our training is not just around cultural competency. Everyone talks about cultural competency, but we realized we really needed to focus on unconscious bias. And we all have unconscious biases. So by having that and doing it in very interactive ways and storytelling and theater, our staff, really now recognize, all of us, where those unconscious biases are and what we need to do to address them. We also, I think, what was what I really loved about the way you framed that question, though, is it's about having proportionate and appropriate representation of these communities at the table, at our governance, at our leadership table, et cetera. So we also have adopted some very specific goals that we are continuing to work on around increasing the diversity of our governance, as well as increasing the diversity of our leadership team. And one of the things that we've adopted, which is widely known as the Rooney Rule in the NFL, we have that same rule translated in our system. So for any leadership position, supervisor or above, we require that there will be a diverse applicant in the finalist pool. And we don't set quotas, we don't tell people who to hire, but we make sure that we are bringing those well-qualified candidates and giving them that opportunity to be considered. And guess what happens when you do that? Oh, by the way, we now have a much more diverse leadership team. So those are just some of the few things that we've done. And then the other thing that we saw with this pandemic that I think was mentioned earlier was, I call it the second pandemic. And that's the racial injustice pandemic that we all, and once again, it wasn't new, but it was brought right to the surface with the murder this summer of George Floyd and all of the other deaths and inequities that had happened prior to that. So we have just reformed, we're 3 months into it, a new governance-led task force. We call it our HEART Force. And HEART stands for Health Equity and Anti-Racism Task Force. And we are committed to continuing the work that we're doing and really focusing around some enhancing our goals around how we are addressing our patient population, how we are addressing our workforce, and how we are interacting with our community and addressing all of the health equity and disparity issues that it's almost unconscionable that we're here in 2020 and these issues are still facing us at the extent that they are. So it's really great to be in an organization that values this and doesn't just talk about it, but is doing something about it. So thanks for that question, Wayne.
Well, thank you, Deneen. And you're really the personification of what needs to happen to make sure that we do have proportional representation and able to, bring your perspective and your life history to impact that organization. Similarly, I know that Bonnie has been a leader in a number of these areas on the West Coast, and I'd like to ask her for a follow-up comment.
Sure. I was just listening to Jason Rose's words of that healthcare is really not based on your genetic code, that it's based on your zip code more so than ever. And that resonates so much with the reality of what we're seeing. And Jason mentioned it's about how do we make sure that our patients, once they're discharged, how are they following their guidelines and taking the appropriate drugs that they're supposed to be taking? So I thought I would share some of the things that I've been able to witness here in California that some of our hospitals are doing. And one of them is the Meds to Beds program. And essentially what it is it's a delivery service with a pharmacy that we've partnered with that partners with hospitals to make sure that our patients are getting the appropriate medication in their hands, whether it's in the hospital or delivered to them within a 24-hour period of going home. And they make phone calls to the patients at 2 days, 7 days, 10 days, and 20 days within that 7-day readmission risk period and then that 30-day readmission risk period. And I think that's an amazing program to offer for our patients who need that extra help and support. Also, in Northern California, we did a partnership with the fire department. A lot of fire departments are starting to do this. It's called a community paramedic program. And basically, they're going to the communities that have a high risk of the frequent flyers for our ED, and then also the high readmission risk patients. And they're doing visits to their homes. And these are firefighters that are so compassionate that are going into these patients' homes and helping them with some of the most basic necessities, but surprisingly, we'll get them right back into the hospital again. And so we're grateful to have those kind of partnerships. Our mission statement for Common Spirit Health has shifted recently. It previously had the words poor and disenfranchised in the mission statement. And now the words are, we serve a vulnerable population. And I think that's a very important distinction that our company has shifted towards, because whether it's me or you, in the middle of the night, if there's an emergency, we're not going to be all dressed up in our suits or fancy clothing to walk into the ER in the middle of a situation. I'll give you a very quick story. I had an instance when I was when I was pregnant, I had a subchorionic hematoma. I'll never forget that because it was uncontrollable bleeding, uncontrollable. And the physician in the ER didn't even make eye contact with me. My bed was facing the wall. For some reason in that hospital, I couldn't go to my hospital because I wasn't close to my hospital. I was facing the wall and the ER physician was behind me, did not even bother to step out of the doorway and did not even bother to come make eye contact with me. And I had to shift my body to move and look up to try to make eye contact with that physician. Why am I trying to do that? Why shouldn't that physician come to me? That's the kind of feelings our patients are feeling. And you know what? That was something so minor, but I will never forget that. And, our patients remember that. And the unconscious bias is so real. There are patients that are treated so disrespectfully and so differently based on how they look at that moment in time, whether you're an executive or not. And so I think it's really important that we take this very serious. The best test of character is how you treat a person when you know you don't have to treat them well. I think that's so important for all of us in healthcare, the way we deliver our care. We are a service industry, regardless of what type of organization we're in. And it's so important that we treat everybody with respect. And I also want to share diversity in leadership. I think, regardless of whether it's age or race, our CEO, for example, she made conscious decisions to build her senior team with people. There was somebody, senior director of business development, very, very green. And she made an effort to bring him on, even though some of the others said he may not be ready. And he's doing a great job. And so I think that, as leaders of organizations, make those decisions, even if it's an unpopular decision at the time, because you want to give that person an opportunity to grow in their career. And then lastly, I just want to say, with COVID, our Long Beach mayor, he lost both of his parents to COVID within 2 days of each other, and he had to keep on going. And it was it's just a stark reality that the virus and any sickness, whether it's cancer or any other sickness, can hit families in such a personal way. And that, we just have to remember that our bodies all respond differently to the same exact thing, whether it's the same virus or the same cancer. And that it's just important that as we serve a diverse population, that we recognize the differences and what we can do to try to help those communities.
Thank you so much, Bonnie. I really loved your example of your observations as a patient, and I really want to encourage, especially the students participating today, that when you find yourself in a leadership position and you find yourself needing patient care, you can get such an incredibly different perspective on what that experience is as you can from your normal management duties and day-to-day office practices, and it's a really valuable opportunity to learn and make change and make lemonade out of the lemon of having to be a patient. The last of the areas of weakness exposed with the closure of schools was the unlevel playing field seen with students learning from home. Technological disadvantages quickly became educational disadvantages. In the same way, technological solutions to existing healthcare barriers can expedite solutions and implementation of solutions, or the lack of access to that technology can inhibit them. Jason, as this panel's healthcare technology leader, how do you see the future of technology to help overcome some of these fundamental problems, including barriers to care for reducing medical spend, as well as including COVID-19 related hospitalizations and mortality?
Yeah, what I'm very excited about is that what I was hoping for in my career back when I was at GW in the early 90s, before when I said I'd like to get a degree in healthcare technology, and they said, "What's that?" And we actually have a healthcare technology field, and it's big. Technology has caught up. Healthcare is still behind, but there's a lot of other industries that have shown us, like banking is probably the best example of how we can do better using technology safely and security and at a high speed. And so you all are familiar with the technology called CRM technology. So the most popular one is Salesforce.com. And that's a customer relationship management platform. So my company's technology doesn't use Salesforce, but we are a CRM. Some people call it a PRM, which is a patient relationship management tool. And so looking at not just a nice workflow tool, which is important, but the data, and not old data, but current data, and using that data, driving analytics based on what we know today and patterns into a clinical workflow platform that focuses on the consumer that is in front of you, either be in the office or in the hospital or on the phone from a remote perspective, is really important. And leveraging, again, available technology that does exist today to drive that consistent clinical workflow using the most available technology, drugs, data, refill patterns, medications that are gaps, diagnoses that are undercoded from a risk score perspective, and then SDOH problems because of past issues. And really systematizing that relationship, and then giving the clinician the opportunity to enable that technology to drive better health. And so what Bonnie just said a moment ago, I think really resonated with me. That the motto we have is that our clinicians which are mostly pharmacists and pharmacy technicians and diabetic educated nurses, about give or take 1,000 or 1,200 or so of them across the country, is to have a mind of a clinician and the heart of a social worker, because it's not just about someone on the phone and the next person up. It's actually about, what does this person need right now? What can I do to make a change in this person's life? And if you have a CRM platform, it's completion of these issues. It's not just out there in some bitter bite on some free text field, which plagues technology installations. It's actually discrete data that the patient said, I don't have access to food. I can't feed my family. How are you going to get a patient who is splitting their pills to focus on that, regardless of how important it is, if you don't have food in your refrigerator? It's not going to happen. So those SDOH issues are really important, but you can use technology to drive improvements. And so another example that Bonnie was just describing that I see happened in COVID in a very big way, particularly in the last few months of the year, is that typically members or patients, particularly with the duals, Medicare, Medicaid, dual eligible SNPs, special needs plans, these are the highest risk, highest cost patients we have that are most at risk for the pandemic and after pandemic. Is they're required every year, the providers, to do a pain assessment and a medication review. And guess what? They're not seeing their doctors. So there's a massive problem in getting pain assessments and medication reviews in 2020, and continuing in 21, because patients are worried about going to their doctor. And so using technology, using remote workforce staff and telehealth, we can overcome those kinds of things. And those are we just literally hired 450 people in the last 4 weeks to overcome that issue for one of the largest health plans in the United States. So those are the kinds of things that you do. And then when you're on the phone and you have that opportunity, what is the transition of care for that patient? What is, if this person was just discharged, making sure the PCP knows patient had these medications when they entered the hospital, they have these medications in the discharge orders, and ensuring that there is a transition of care to the doctor, the pharmacy. Don't take this statin, take that statin, although it'll end up back in the hospital. That impacts quality of care, impacts quality of life, costs, hospitals, and for the plans. Everyone's aligned on that. So I do see a really important aspect of how we can use tech to drive these things. And it is important to take one patient at a time and solve those issues.
Thank you, Jason. Can you give us that quote again about the mind of the social worker?
Yeah, so I can't take credit for it. It's my chief adherence officer's. Her name is Cindy Alexander. It's her quote. But it's the mind of a clinician and the heart of a social worker.
Wow, let's give her great credit for that thought, because it's very, very. So we have enough time for a couple of questions, and we've got a number of them coming in from the attendees. The first one I think is best for Dr. Dixon. Dr. Dixon, there's evidence that the pandemic has also disproportionately affected smaller, financially stressed hospitals and medical practices, especially those with significant community obligations. What's your experience with pressures on medical practice during this pandemic?
The pressure is significant, and it is, and practices and small community hospitals are collapsing under that pressure. Period. My experience before coming to Coliseum Medical Center was at a small surgery center in Kansas City, Kansas. And it's in it's in Wyandotte County, which is a part where there are not a lot of medical facilities. There are actually two. In fact, you could draw a map in Kansas City, and you can look at Johnson County, where there are several major health systems with several major health facilities, as well as small urgent care centers and freestanding ERs and private physician's office in Johnson County, where a lot of the wealth is concentrated. And in Wyandotte County, where my surgery center was, there are only two facilities. And one of the reasons I'm here in Coliseum is because that facility succumbed to the pressure of COVID, of not being able to do elective surgeries, and not being able to service the community with COVID patients or other critical care patients. And so they succumb, leaving that part of the county even further behind in terms of facilities, and which translates to access to facilities and care, and the dominoes just keep falling. So the pressure is significant. But as has been mentioned more than once today, these issues didn't start with the pandemic, and I don't think that they'll go away with the pandemic. And so there should continue to be focus on all the social determinants of health, all of the forces that created those social determinants of health, and all those forces that created the issues of diversity and access, why we have them, and address it at that level before I think we can begin to turn some of those tides.
Okay, thank you, Dr. Dixon. I think we all, again, back to some of the things that Bonnie said about the ability to respond to disasters that are geographically contained and of short duration is one thing, but this is an entirely different animal, and those as you say, those dominoes are going to continue to fall for some time in the future. We'll fit one more question in. This question is from Kayla Cooper, and who's an alumni, and she's directing it to Bonnie and Deneen. What kind of resiliency programs are your organizations incorporating when dealing with staff loss due to COVID? And with our time, if we could have about 1 minute from each of you in response, starting with Bonnie, please.
Okay. Originally, I was going to ask Deneen if you could go first. That's a really tough question because you never feel like you're ever doing enough. It's such a hard situation that our employees are having to go through. And, we can offer as many nice amenities as we want, but at the end of the day, we can't take that pain away from them. We can't take away what they're witnessing. And so I think, as much as we can, just be visible, be there for them emotionally, talk with them. We have an open door policy. All of our leaders have really stepped up. I'm so proud of all of our managers and directors in the organization. They're the ones that are the lifeline to be able to hear the venting of what our employees are going through. And so in a 1 minute answer, I think that's all I can offer because I think that's all we can do.
Yeah, good. Thank you. Deneen, you answered a lot of those questions about resiliency, but can you add anything more to Bonnie's comments?
Sure, and I'll be very brief. I think right now we have to think about loss in a couple of ways. So we have our staff, who are our caregivers, facing losses when you look at the mortality rate that we're seeing with COVID. And then many of them have had personal losses, and probably not anyone here who doesn't know someone who has, who has passed from COVID or related diseases during this period. So we focus on a couple of different things. One is just wellness. And then we also focus on well-being. So we have, during, even if it's just like short periods of time, to have people go into a meditation room. We have those. We've stood up some additional meditation rooms, relaxation activities, places where they can vent, whether that's through someone that they work with, calling the employee assistance program. And we also have really pulled on our chaplains and our spiritual care providers to support our staff. And then when people are facing personal loss, whether it's a loved one or a neighbor or whatever that might be, we're just trying to support them as best we can. One of the things that we say is we tell our leadership team, just reach out to them, call people, see how they're feeling. We send them a card, send them flowers, check in on them, the same things we would be doing if it wasn't COVID. And as busy as we are, we have to make time for those human connections. So I'll just end it with that, because there definitely is a lot of loss that people are experiencing. It's going to be so important that we support them, and also supporting people through all of their mental health needs, which is another area that's exacerbated due to this pandemic.
Thank you so much, Deneen, for that comment and making it so meaningful. Kelly, you know how to put together a panel. We all have to give you credit for that. Thank you, everyone, for making this panel so meaningful. It has been a day of learning and connecting for us all. I'd like to, for us on the panel and those who put on the program, but for everybody listening, I would like to take note of the comments in the last few days of Dr. Robert Redfield, head of the Centers for Disease Control. And quote, "The reality is December and January and February are going to be rough times. I actually believe they're going to be the most difficult time in the public health history of this nation." End quote. The work that you do every day since we started this fight has been crucial to the health of the nation. To the doctors, nurses, PAs, epidemiologists, and all of you who are on the front line, and to all of you who support them through your management skill and leadership, we thank you. I want to thank everyone in the Zoom call today. Stay with us here, because coming up at 2 p.m. is our 14th annual COIL lecture featuring Dr. Lauren Powell. But right now, please join me in welcoming MHA Student Association President Laura Gruer, followed immediately by the presentation of the 2020 Frederick H. Gibbs Award for Excellence in Education. Thank you, everyone.
Hello. Welcome. Thank you so much for joining us today from wherever you are in the world. My name is Laura Gruer, and I'm the president of the Masters of Health Administration Student Association. I've had the pleasure of working with our students over the past year to really improve our program for cohorts to come. Over the last summer, I really worked closely with the leadership at the George Washington Outpatient Rehabilitation Center to improve the communication to the surrounding metropolitan area. This position would not have been possible without alumni like you working closely with our students to find internship positions and opportunities to really enrich our program experience for students. This internship really provided me with an experience that to expand my view of healthcare and really just to see it in its purest form. I was really able to have an experience that I could speak to in fellowship and residency interviews, and it really opened the door for me to move into a residency position at Johns Hopkins Bayview next year, where I'm really looking forward to continuing my communication with current alumni there and other positions there as well. If you're interested in working closely with students like me and our current students, please don't hesitate to reach out to the email on the bottom of the screen, and we'll be sure to put you in contact with our current board members with our SAMP mentorship program. We have a program in place where our students are matched one-on-one with alumni, and it's really based off of your interests and their interests, and you really have the opportunity to build a relationship with them so that you can continue to work closely and foster a more long-term meaningful relationship with students. Thank you so much again for joining us today and your continued support of the Masters of Health Administration program. I know I personally have been forever changed by your continued involvement in this program. Thank you again.